What if this happened to you?
I'm gonna take care of you, okay? Do you know where I am? Try to keep your eyes open for me, okay? Can I get you to follow the light for me with your eyes? Don't move your head at all, okay? Don't move.
You find yourself in an emergency room. You've been in a very serious accident and are going in and out of consciousness. You're in great pain. Or maybe you've had a massive stroke and can't talk. Or worse, you're in a coma. The medical team will ask your loved ones if you happen to have an advance medical directive. Those are written legal instructions that tell your medical team what kinds of treatments you want and don't want if you're not able to make those decisions for yourself.
We really want to know what it means to take care of you as the person in front of us, and how can we provide you with the best care that you want. And I can't, as a clinician, force that on you, but I can celebrate when you tell me, because that's really what I want to know.
That's Dr. Nneka Sederstrom, the Chief Health Equity Officer at Hennepin Healthcare in Minneapolis, Minnesota, and co-founder of Uzobi, an advanced care planning tech company that's developed a digital, ethical medical blueprint. Also joining us is Bud Hammes. He was La Crosse, Wisconsin-based Gunderson Health Systems clinical ethicist for some 30 years. Dr. Hammes' work at Gunderson led to the internationally recognized Respecting Choices Advanced Care Planning program.
But we're not talking about death and dying. We're talking about what it means to live well. That's our starting point. And then you can engage people.
What goes into an advanced care directive and why you need one. That's on this episode of Grave Concerns, a podcast from the End in Mind Project. I'm Kathy Wurzer. I am glad you're with us. Say, have you ever heard of advanced care directives? You'd be forgiven if you haven't. A 2025 Harris poll shows more than half of Americans don't know what the term means. It's interesting to note that there's also new survey data that shows the majority of Americans want control over end-of-life decisions, but most have not documented those preferences in writing in an advanced care directive. Well, I am honored to talk about the whys of advanced care directives with two experts, both PhDs with long experience in medical ethics and philosophy. Bud Hammes started our conversation by recalling what sparked his interest in advanced care planning. There were 3 patients within 2 months at Gunderson Medical Clinic in La Crosse who were all getting life-saving treatments for kidney failure.
They all suffered devastating strokes from which they were not expected to recover any cognitive ability. And the question was, should we continue their dialysis and keep them alive in this devastated neurologic state, or should we stop? And I was asked to come and speak with each of the 3 families to help them process that decision. And to make the story short, all of the families told me the same thing. If we only knew what our mom or dad wanted, it would be so much easier. And then I did some research after we processed those decisions, and the families all decided to stop, but with great distress. Moral distress about whether they were or weren't doing the right thing, because they did not know what their parent would have wanted. They had never discussed it. And so I wondered how often this occurred. Was this 3 unusual cases and I just happened to have them in 2 months? And it turned out that there was a review of end of life by a Swedish nephrologist who reported that 50% of the time worldwide, someone other than the patient decides to stop dialysis. And that's when I realized that this was not unusual, that this was very common, that the physician, the family, someone other than the patient was making the decision to stop dialysis. And so I approached the dialysis unit and the nephrologist at Gunderson, and I said, could we implement a program to try to help dialysis patients talk with their families about when it would make sense to stop if they couldn't make that decision? And there was a lot of skepticism, but I got support and we implemented a program. This was before Respecting Choices was developed. And what we determined was we could engage patients and their families. We could have conversations. We could document those conversations. And it was of great value to everyone to the patient, to the family, to the physicians, to the hospital, when we had spent a little time doing these conversations in advance, documenting their preferences, involving the family, getting that recorded in the chart, because all of a sudden, when we knew what the patient wanted, deciding whether to stop or to continue was relatively straightforward.
Wow, that's a story.
And in one way, the reason respecting choices became a thing in lacrosse is because one of the medical leaders was a nephrologist who witnessed the positive outcomes of this initial program with dialysis patients. And he stood up in front of the medical staff at Gunderson when we were rolling out respecting choices, and he gave a testimonial. And his testimonial was, I want my colleagues, the physicians in this organization, to know that this kind of conversation with patients and families works. And as a physician, it makes my job easier, because when I go to talk with families, when my patients are incapable, they almost always know what to do. So my conversations are shorter. It also means, as a physician, I know what my patient wants because it's been documented and the family reported. And so I know I'm doing the right thing. So it's easier to do. And as a physician, I know I'm doing the right thing for my patients because they have recorded what they wanted. And I sleep better at night.
What's your experiences, Nneka?
Similar, except my first one was a infant death, and it was an infant death in utero. So it was even more problematic. I was a very young, straight out of college, bioethics intern at Washington Hospital Center in Washington, D.C. And I was basically working for free because I had told my parents that I was going to take a year off to gain experience to know what my next steps were, but I also had no idea what I was doing, but I knew I wanted to do clinical ethics. So when I found the Hospital Center for Ethics, I felt like this was heaven on earth. And so I was just sitting as a young intern to just hang out in the space. And the first case that I went to that was death was a pregnant woman who had significant psychological issues. She had severe mental health issues, was in a group home. No one knows how she became pregnant. She was incapable of even understanding that she was pregnant. And the struggle was the baby was in distress. They needed to do a C-section. But the dilemma was, how do you do a C-section safely on someone who doesn't even understand that they're pregnant? So can they therefore understand how to care for themselves post-op, as well as the fact that they were in a group home and didn't have anyone else around to help them? So there was this massive pause to try and figure out what is a safe mechanism for the baby, for the patient. And there was no clear, straightforward answers. And it was a very rushed scenario, obviously, because labor doesn't wait for anybody. And we had to quickly have the courts intervene to get a guardian for the baby and then a guardian for the patient. And then the lawyers started stressing about, what do we do ifs? And we had to bring a judge into the hospital and take up a family room with all of us there trying to figure out what is the best next steps for this patient, while also finding her mother and bringing her in to try and maybe help with decisions. And when all this chaos is going and I'm watching everybody struggle with, how do we keep everybody safe and what do we do that's going to be in the best interest of the patient, and no one willing to kind of make a decision, one of the nurses came into this chaotic room and just like basically pushed the door open and said, the baby died. And we were just like, wait, what? And she said, well, you all were still trying to figure out what to do. The baby died. And she just walked out. And it was like this massive weight of what just happened. And of course, why didn't anybody tell us the babies was in distress? Like all these questions started. But for my young 22-year-old mind, the thing that imprinted on me the most was, why were we struggling to be decisive? All of these what if questions that everybody was worrying about didn't really matter when the decision should have been clear. the first and foremost, we need to take care of the human in front of us, and then we'll figure out the other stuff later, right? Like that to me was really clear, but it wasn't that clear. And I didn't understand why it wasn't that clear. When death was the possible outcome, it felt easier to ask questions of what would you have wanted if this was you? What should we be focusing on? Because this is the possibility of the outcome. It's not just infirmity or some sort of comorbidity. Death is the outcome, right? And what do we do to respect the human in front of us while this is a possibility for their life? And the judge was very angry, as you can expect. Everybody felt really sad and defeated and angry for multiple reasons. And I remember thinking to myself, when it's time to make decisions around death, the thing that I think is the most helpful is to be really clear and direct. It's the uncertainties that cause pauses that end up hurting people more than helping. If you know the outcome is going to be death, then we need to make sure that that death is the best outcome, the best version of the outcome that it can be. If we're not sure about that, that's a different conversation. And if people have the opportunity to talk about the what ifs and help people understand what they want for them to make that death feel for their families and for their own mental health and well-being, that when it's their time to die, it's going to follow along the continuum of how they live their life. That also brings down the uncertainties that makes people feel less worried about making decisions in the chaotic time and more secure in their decision making. And that was my first death. I've had many, many, many other cases since then. And I think that one of the elements that I learned the most from that has helped me in my career as a clinical ethicist, and then now with my company, Zobi, and helping people make decisions about themselves early, is the ability to just be direct and clear on what you want and have that lead and guide conversations. I think we oftentimes forget that it's a guidance, a conversation doesn't necessarily mean that's exactly what's going to happen, but at least gives us a starting point. And this case had no starting point other than all of the social complexities about this woman. They were more worried and cared more about how she became pregnant than the fact she was pregnant. There was all these extras out there that no one paid attention to the element that was most important, which was her safety, the baby's safety. And if death was an option, how do we make sure that that either happens the right way or doesn't happen? And we missed the boat on that.
You mentioned clarity. I've often heard that a major weakness cited with traditional advanced care planning is that preferences can change over time, right? So how do you deal with something like that?
Well, that's one of the things that I made as a requirement in my medical blueprint, which is more than an advanced care planning document. That's included in it, but it has to be living, right? We have to continuously have these conversations. And as Bud mentioned before, it makes physicians' lives easier. But the struggle is timing and making sure that people remember they're supposed to ask, right? And so what we did is we put in a notification system that every 6 months, it just says, hey, are you still good with these? Yes, great. No, okay, time to change, because healthcare changes, right? You're fine today. Tomorrow, something catastrophic could occur and your mind is completely off the directive you have in your safe from 10 years ago. My mother-in-law, her directives has my husband's cell phone number on it, right? Because that's what she thought, but that's now her phone. She took his cell phone and now the number that's on there would be calling herself instead of my husband, right? So these life alters, and we never take a second to go back and be like, oh, what were those papers and how do we think about it? But if there's a normalizing of these conversations, and it's not just what do you want at the end of your life, but what do you want regarding your healthcare, which includes taking care of you as you die, then it'll be part of the normal discussion on, have there any wishes that have changed? Have there any value systems that have changed? What now seems more important than you thought it would have been before? When my first directive was at 23 years old, I guarantee you now at 46, the things I thought were important at 23 are no longer important. My children are now more important, how I want to be around my children versus when I was 23 and what I worried about my parents would think if I was dying versus now what my children would think and how I want them to remember me. So we have to make these things not just flexible, but continuous living documents that are triggered in some way, shape, or form to just keep up with your life. Keep adding things or taking things off as your life changes and flows.
Yeah, so probably one of the most important things that everyone should consider, and I believe should do, is to appoint another person to be their healthcare agent or decision maker should they become incapable. Because as long as you're capable, you should be the one in charge, and you will, and hopefully will be the one in charge. But any of us, no matter what our age or health, can become incapable. Automobile accident might be the most obvious choice, but there could be strokes or falls or whatever. The thing that I learned early on is that saying you should select a healthcare agent or decision maker seems like an easy thing to do, but I saw people making mistakes in making that selection. And so one of the things that we started to process is, what questions do people need to consider when they're picking someone? And what we came up with were 3 questions. First of all, can the person you are selecting make complex decisions in stressful situations? And I can't tell you how many times I was talking with someone who had picked a spouse or picked someone else in their family. And when I asked them this question, can this person make complex decisions in stressful situations? They'd go, no. I always make the decisions because they simply fall apart. Well, let's think about someone else then. So I've seen cases where someone who picked their husband all of a sudden decided to pick their sister. Now, the husband needs to know that. I mean, this should not be a secret, but you really need someone who can think about these decisions, stay calm, understand the complexities, understand how your values are. And so that's the second question. Can you talk with this person about what's most important to you? Because if you can't have that conversation, they have no guidance. And then the third question is, will they honor your values and preferences, even if they don't agree with them? Because their job is to represent you. So once we started to do this, we found that we could get to the best decision maker, maybe not the perfect decision maker, but at least the best decision in that person's life. And then the second part was, what is the process of decision making that you would like this person to follow? Should it include other family members or a pastor or a priest if there is time for that to occur? And so some people were resistant to say, well, I don't want to pick one person because in my culture, in my family, we usually make decisions together. And my advice is, you need to pick one person who has authority, but then you can direct them to include the people you want if time permits. So in one case, I was dealing with a decision where we had to make a decision about inserting a feeding tube on someone who was neurologically devastated. He had appointed his 3 daughters as equal decision makers, and one of them was up north and unavailable, could not be reached for another 10 days. Her husband were on some Canadian lake fishing, and we could not contact her. So were we going to put off this decision? Well, we couldn't wait 10 days. He would die. So were we going to insert a feeding tube when the 2 daughters were saying no? He doesn't want that because the 3rd daughter wasn't reachable. It's just not, so my advice is you should have one, more than one person, but one person who has authority. But you can also tell that person what other people to include if time permits. The flip side to this is, are there people you want excluded from that decision process? Very many of us have a family member who's disruptive. I'll just put it gently. And they always turn over the apple cart when there's any family big decision to make by being emotional, by being crazy in some way or other. And so that was the other part of this process, is to say, who are you going to appoint? Can this person carry out the responsibility? If there's time, who else do you want to be involved? And then third, is there anyone you want excluded? I can tell you as a hospital ethicist, if someone's document said, I do not want Uncle Harry to be involved in any of my decisions or be involved in family meetings on my behalf. As a hospital staff, it's now possible for me to say to Uncle Harry, sorry, you're not welcome into this room.
And someone else have to deal with the fallout of that,
Well,
obviously.
but at least you have authority.
Yes, exactly.
It isn't now the physician or nurse's decision to exclude Uncle Harry, even though that may be a perfectly fine idea. But you have the patient's permission and authority to say, sorry, Uncle Harry, you cannot participate. You don't have to tell them why. You just say, you can't come in this room and participate. All of those things tremendously help. So I'm not disagreeing at all with what's already been said. It's just that this is something all of us should do. Who's going to make your decisions? Are they capable to do that? Are they the best person? And then what process of decision making would best represent your family, yourself, and reach the best decision?
So when you mentioned decision making, and you kind of gave us a picture here in terms of potential problems with family members, because family dynamics are obviously fraught and problematic at times. Is that often the sand that is thrown into the decision-making gears, or are there other things you have to worry about? Nneka, I'm going to throw that to you.
Oh, there are a bunch of stuff. I mean, I often said I could write a book on like family meetings and the things that go sideways, but you had no idea were expected to go sideways. Even with a clearly executed directive, everybody understands what's happening. You have a decision maker who was part of the conversation. Seemingly everything went smoothly. When the decision time comes, they could completely fall apart, right? So it is one of those situations where the more the merrier, right? The more people who understand, the more people who are clear, the more times it's been talked about, the easier it becomes because the decisions are challenging. They are hard. My decision maker was not my parents when I was younger. It was not my parents because I knew my mother incapable, completely 100% incapable. It wasn't going to work. My father would have been devastated as well. My best friend, who was studying to become a pediatric intensivist, perfect. But I also needed to make sure she knew, and my parents knew, was she needed to be able to manage the emotional distress of my parents. And I told my parents, she has permission to kick you out if you can't do it, right? And she may have fallen apart if something had happened, but you try to normalize the conversations enough so that when things happen, there is at least enough people to say, well, you know what Nneka would have wanted. So let's talk this through, right? We may not have wanted this, or she may not have specifically decided this scenario, but the clinical team has a good understanding of her wishes and wants. And I think that the evolution of directives is really important because we've gone away from the really generic, nobody really understands, do you want to be kept on life support, X, Y, and Z? With all the technology we have now, what does that even translate to? To more specific, intentional conversations. Like in our medical blueprint, we ask very deliberate things like not just a ventilator, but what kind of ventilator? Are high flow fine? Is a nasal cannula fine? Do you want no oxygen at all? What if it's an opportunity for a temporary situation versus extended? Because when clinicians get into the situation of having a generic, I don't want to be vented, that doesn't help explore the multitude of opportunities in between what is vented and what's not vented. And what a good directive and a good conversation with a decision maker leads to is, okay, so the end all be all is I don't want to live vented for X or that be the end of my story. I am fine with being vented if it's a temporary scenario. I am fine with a trach if that means I still have the ability to be with my family or do the things that are valuable to me. The old world directives never had the space for that, but now we're doing much better in clarifying. And that has decreased the amount of stressors that occur because oftentimes the clinical team will get stuck. They were like, I have a directive that says, I don't want to be vented, but this patient's got to go to surgery and they're going to have to be vented for a little bit. So does that mean there's no surgery? Does that mean that I'm now violating their directive? Do I have to ask the family about that? Or do we just continue on with the conversation? And that swirl, that uncertainty, that's where all the problems are. And that is the big thing that I've always been really clear has to be addressed is let's minimize the uncertainty around these situations as much as possible so that we increase what I affectionately term ethics flow and we take away the barriers. And ethics flow is just that you can flow through the entire system from start to finish without anything getting in your way because we've opened up enough communication pathways that when something comes up, there's enough information and trust in the communication that we get the clarity much quicker instead of it being a barrier.
I bet you listeners are probably thinking the same thing. So Nneka's saying we need to be clear. Yeah, absolutely. But things change, right? So I'm wondering, do you run into physicians who say, I'm seeing this here on this piece of paper, but I think something different. I mean, in a sense, does an advanced care directive kind of tie the hands of physicians?
Well, this idea of ongoing planning is important because what do you plan for when you're a relatively healthy adult person? So you should pick someone to make decisions in the way that we've already described. The one thing that everyone should think about is how bad would a neurologic or brain injury have to be? Assuming that it was a permanent injury, that is, would never get any better, for you to say, if it was that bad, the goals of care would no longer be for medical treatment to keep me alive. Because that's one situation where we don't ever get a second chance to plan. Something could happen, an automobile accident, a tragic fall, a stroke, a heart attack leading to anoxic injury. There's lots of causes, but what I realized in dealing with lots of ethics cases is that patients at any age can have a severe brain injury, leaving them incapacitated. And we can't ask them ever again, but we could keep them alive. Would they want us to do that? And this is one of the most distressing moral questions for a family who don't know, because on one hand, we could put a feeding tube in, we can give them good nursing care, and we might be able to keep their bodies going for years. Would they want us to do that? Now, I can tell you, looking at thousands of advanced directives at Gunderson, because I have checked this out, 99% of the time, people say, if I don't know who I am, if I don't know where I'm at, and if I don't know who I'm with, don't keep me alive using medical care in that situation. It is no longer important for me. It's no longer a goal of care. That's an important kind of measure. And because it's not 100%, there are some people who will say, for religious or whatever reasons they may have, yes, I do want to be kept alive. Now, whether that's an ethical, social justice issue, that's another whole question. But we should know what their preference is. And so that's one situation which I think is clear. And people say, well, how do you know what the outcome is going to be? Well, sometimes we can determine that within weeks. Sometimes it might take years to know whether it's permanent. But we can tell that they're unconscious. And what we discovered at Gunderson, once we started asking this question, is that when such events occurred, and it was clear that this patient was not going to recover or was very unlikely, families would approach the physician and say, we know what our mother wants. We know what our brother wants. He does not want us to keep him alive in that situation. And so the whole family meeting changes its complexion when the family clearly understands that the patient's goals of care would dramatically change should they suffer a permanent, severe neurologic injury. So that's one thing that we all can answer, and we have to answer it in advance because when it occurs, by definition, we won't be able to be asked.
Nneka, in the medical blueprint that you have, is the client able to be really specific about these issues? And then, as I say, can the physician look at this and say, I don't know if this is a really great idea? How does that work?
Not only can they be specific, it is designed so that they are specific. They can't be generic because it's built off of 20 plus years of ICU medicine, basically, and knowing what it is. And I think at the crux of it all, it's really understanding what people's values are, what's important to them from a value perspective. And it's more value-based than situational space, right? Because if I value walking my dog, and that is the thing that brings me joy every day, I personally don't know, because I'm just a random person that uses the healthcare system for my COPD. I don't know that there are various versions of oxygen tanks out there. I just know what my doctor gives me. But if my doctor knows that I value walking my dog, then it will be problematic for my doctor to give me an oxygen tank that requires me to stay at home. It would be better for them to give me an oxygen tank that I can take with me. What we see happens in these kinds of spaces is that the physicians don't have the time and they don't have the space to ask these kinds of questions. So what the blueprint does is it looks at values, it looks at things so that it avoids situations where a COPD person comes in COPD exacerbation, ends up in the emergency room. Now they're going to be in the ICU, and now this trickle effect, and the clinicians feel that the patient was non-compliant, which puts this problematic patient mark on their record of non-compliance. But the reality was it just didn't work with their life because we didn't know that they valued walking their dog. So they were not compliant with the system we set up with, and instead of giving them an opportunity to be compliant. And it's that concept of, if I just tell my doctor things that matter to me, then they can personalize the medicine to fit me so that I can be better with the outcome. So the conversations happen smoother. So when I face the end of my life, well, what did I value? What were the things that were important to me? My family was important to me. Being free of pain is important to me. Making sure that, Uncle Harry doesn't show up is important to me. Like, these are the things that people will know as the situational guardrails, so that when that specific thing comes of whether or not a feeding tube or a ventilator or an LVAD or whatever the new technology is, those questions can now be asked within this sphere of understanding the value of the person, what they want to have as their life, and how to live their life as long as possible in a manner that fits them. There will be some people who believe being vented for a certain amount of time in a nursing facility is fine for them because what they value is time. And when you see that on a directive, the clinician's job, which a lot of good physicians do, is to say things back to their patients like, I see that this is important to you. Let's talk a little bit more about the why. And let me explain things like, we don't live in a culture where there's beds open for in perpetuity, right? Like, it just doesn't work that way. So let's talk about maybe home care services. And do you have the money set up for that? Because if this is the wife you choose, this is how it's going to have to go down, which is a better conversation than someone feeling like, I've been told I must keep this patient alive because this document says that without contacts. And I personally feel like this goes against what I believe is my best interest for my patient, right? Like, our duty to take care of our patient. That's conflicting with my internal duty to provide the best care that I can. And it shouldn't be a conflict. We should have enough time and opportunity to have conversations and learn about who our patients are, to be able to say, okay, so the context was this patient really never wanted to live in a persistent vegetative state for X amount of time. I had a patient who did her medical blueprint prior to going into surgery, and she and I had a consultation because I noticed when she filled out the end of life section of it, she put on there that she wanted to make sure that if CPR happened, it didn't last longer than 15 minutes. And if it went longer than 15 minutes, then she wanted it to stop. And for me, I was like, that's triggering something. There's something there. I could have left it and been like, oh, that's her directive. And then she gives it to her doctors and move forward. But I called and I had a conversation with her and I said, can you help me understand the 15-minute rule? Because I can tell you how that's going to translate in the hospital. You're going to have a young physician see this and go, so what happens if it's 14 minutes and 29 seconds, right? Do I, and I think that it's time to call it. Must I continue to 15? Or what happens if at 15:02, she gets her rhythm back? Does that mean that I went against it, right? As like, these are the things that are going to cause them anxiety and they're not going to be able to provide you good care. So let's talk through, what are you actually trying to say with this? And she worked in a TBI clinic. She understood what irreversible neurologic trauma looked like. And her goal was to just not be in that state. And so she automatically assumed that after 15 minutes of CPR, there was irreversible brain damage, and therefore she didn't want to be in that state. And I was like, you know what? Let's edit the words to say, if I'm in this situation where I have irreversible neurologic damage, that means that I will be in a persistent vegetative state with no hope of meaningful recovery. And we defined what meaningful was, right? She wanted to be able to talk, walk, feed herself, like no hope of meaningful recovery. Then I am okay with withdrawing. That clarity before she went into her surgery helped her physicians immensely. And what happens is you can fill out this directive, but you get a nice little snapshot, one pager, because docs don't read more than that goes to the physicians. And they get a good sense of, these are the things my patient values. This is the system that they want to live in. Like, this is how their life is supposed to work. These are very clear points that they have that are just non-starters for them. So please couch their care in a way that makes their whole person included. If she has an incident in her surgery that results in an irreversible neurologic brain damage, she is okay. And her family is very clear. She's okay with withdrawal at that point.
I want to know from both of you. It's this, in terms of these conversations that patients should be having with their physicians. But when you're in an office, and Bud, you know this, you've got 15 minutes or something, and you've got other things you're thinking. Yeah, exactly. So are these conversations actually occurring as they should?
Well, when we first rolled out a community-wide program based on physician feedback, the physicians initially said, this is our responsibility. So we rolled it out with physicians carrying out the obligation to have these conversations. It was about 2 months later, after multiple feedback from physicians, with all basically saying the same thing. Well, two things. I don't have time to do this was the predominant one. There's no way in my schedule I can fit this work in. And then there was a minority of physicians who said, I don't want to do this. I was never trained to do this. I don't think this is my job. And these tend to be more specialist anyway. So I'm taking care of hearts or I'm taking care of kidneys. They just didn't see it as part of their medical training to do any kind of person-centered care, which is a whole nother discussion. So I came back as a kind of community leader and say, what if we train people to have these conversations who are not physicians? We eventually called these people facilitators, advanced care planning facilitators. And then we developed a training program and we got everyone on board, including physicians. And so we were then able to provide this level of discussion that's really required through these facilitated discussions. And fortunately, at that time, there was a little surplus in the healthcare budget of local institutions to support this work. And so our data that we tested 2 times, we looked at the time of death, and anywhere from 96 to 99% of people at the time of death had a written advance directive in their medical record, and it was followed almost universally, reliably. Now, that starts with having someone who can sit down, not just with the patient, but with the patient's family and process this decision. And let me just say what I think in looking back, I'm not sure. I mean, I think documenting this is important. I think having some evidence in the medical record is of great value. Mm-hmm. But I think the thing that really made it successful is having those discussions with families. And I call this rehearsal. These are decisions which almost no one has experience doing. And when you don't have experience doing something, whether it's in carpentry or decision making, you create anxiety, you carry distress, and you have avoidance. So people don't know how to do it. They don't like to do it. They want to avoid it. They might choose the easiest path, or they might just run away. If you can get people to rehearse complex medical decision making, you're actually preparing them through those discussions, and they're thinking about it to actually behave differently when they have these family meetings in the hospital or wherever they're occurring. Looking back, I think the process of advanced care planning is actually a type of rehearsal to make complex medical decisions. So even if the decision you're facing is very different than the one you talked about, all of a sudden you kind of know the landscape a little bit. You kind of know the language a little bit. You kind of know what that feels like, and it doesn't scare the hell out of you and make you want to run away. So I think the process of planning is a type of rehearsal that prepares people to actually step up and make these decisions when the decisions have to be made.
Nneka, what do you think?
Yeah, I completely agree. And I think that one of the concerns I've had over the years of doing this is that the language doesn't really translate well cross-culturally. And I think that we run into normalizing how Americans talk about death very differently, and not even just like white Americans talk about death, right? And it's a very different way than other Americans and other cultures that are in America that end up using our healthcare system. And so what I am hopeful, and now sort of a lot of the work that it's happening and what we tried to do with our blueprint is to change it from a conversation about death and dying, which can be a cultural barrier just by saying that, to a conversation around how you want to live. Mm-hmm. Because we live until we die. So when we start thinking about our death, people shut down in general. It takes very different kind of minded folks to be able to be okay with talking about mortality, right? I mean, I can't tell you how many times when I was young, I'd come home from work and my mom would call me and be like, how was your day? And I'd be like, oh, it was great. My patient died today. Like, this was a great day. And it would mortify her. And it's like, but I know what like life looks like when it's being lived well. And I know what death looks like when it's dying well. And I'm okay with both of those things. And I talk about them regularly. I know what a bad death looks like as well. And I really hope and try hard to not let that happen to anybody. So to be able to say it was a good day because my patient died well was something that I was very proud of, but my mother couldn't handle because the concept of death is just really hard for her. So if we change it from conversations around the what if something quote unquote bad happens to what do we do as we're going through this thing called life, and the life has bumps and bruises and all kinds of barriers, but let's set up an environment in which you can live your life until you're not living your life anymore. What does that look like? And how do I take care of you in the healthcare system in a manner that maximizes this living your life well? So what does that include? That does include talking about things that may interfere with your ability to live your life well. How do those things work with how you see it now versus how you see it later? As a 23-year-old, the concept of being in a wheelchair was a struggle for me. That was not something that I felt would be good. I was an athlete, all these other things. Now, with how my knees are going anyway in my back, and I'm like, I would rather be pushed around anyway because I'm already hurting, right? It's a very different view. And so when I have conversations about how do I want my care to proceed, I want my physician to feel that they can normalize living conversations around me instead of the anxiety that they have around talking around end of life conversations, because they feel that that's kind of anti what they were set up to do. So with our brew plant, it goes to your doc early. They don't have a lot of time to have this conversation, but they get a sense of what are the things that are important to you. And it is part of your medical record so they can fit it in. I tested it out with my mom first. She did her medical blueprint, sent it to her primary care. I sent her off to her primary care appointment. And I asked her just kind of cold turkey, did things change in how your doctor started talking to you after he got your blueprint? She's like, yeah. He said to me like, oh, thank you for sending me that document. I had no idea. So let's talk about the way you want to keep walking in the mall and do your shopping because your arthritis is starting to kick in. And had a very different conversation than, hi, Miss Elaine, how are you today? Is your back still hurt? Well, let's try this new med. My mother hates taking medicine. So it changed to a PT conversation over a medicine conversation because he understood how the things that were important to her that keeps her going and keeps her living. And that was like, that's all I wanted. That's all I wanted was to him to have a better conversation with you because I'm tired of fighting. And I think that that's great. And so if we switch from this doom and gloom, we have to talk about the what ifs because you never know what life happens. Because America is not a culture that thinks that way in general. And we open it up to being as inclusive as we can for how cultures think across the globe of just everybody wants to live the best life that they can live. And we put it in those contexts of what's important to that. I think we will have a better acceptance and universal use of advanced care planning documents than we currently do because they won't feel as threatening and people won't feel like it's not their job. And doctors won't feel uncomfortable with how they bring up death to a 26-year-old who's in there for a knee surgery. All of that weirdness will go away. And we can just talk about how to take care of you with the life that you have.
But I heard you on CBS Network News a while ago talking about this very same thing in that you said it's really not about the dying part. It is about living.
Right. One of the core features of the facilitated respecting choices conversation is the question, what does it mean to you to live well? So perfectly agree, because that's what we need to know from people is what does it mean to live well? And there's a lot of commonality. And it's one of the things that I think has made the respecting choices approach, which probably is never different, successful. I mean, we've taken this program to Australia, to Germany, to Canada, to Singapore, and it's been very successful in Black communities throughout the United States. And some of those get tweaked a little bit, but everyone in every population, every culture we've gone to, it's been interesting because the initial reaction is, oh, you can't do that here. We don't talk about death and dying. And it's like, yeah, but we're not talking about death and dying. We're talking about what it means to live well. That's our starting point. And then you can engage people. And then you can get to, well, what if you had a severe neurologic injury from which you're not going to recover? Would that fit living well? That would or wouldn't, depending on the answer. But it starts out finding out who this person is and what it means for them to live the best life possible. And then you fit your treatment decisions and your plans within that context. And that's comfortable for everyone to do.
So I'm hearing you all talking about the importance of having the conversation, right? And Respecting Choices has been a program that has worked very, very well, as you say, across the world. Here's the thing, though. People agree that there should be these conversations, but there's the follow-through isn't really happening. So what's going on there? What's the barrier, do you both think, to having these admittedly difficult conversations that result in some kind of a plan for your provider? Nneka, I'm going to start with you.
Yeah, for me, I think the barrier is the fact that we as a healthcare system have still kind of put the onus on physicians to figure it out, which is unfair. They have way too many things that they're trying to do within a system that is not designed for them to do it very well because of timing and patient loads and burnout and all the things that we know that they're dealing with. We haven't done a good job of creating a healthcare system that allows for these conversations to be done meaningfully and consistently. So what I think has to happen to fix it is that we take it out of that space of this is the doctor's job and put it back on the individual. You can sit while watching, I love Korean dramas, right? So while I'm watching Korean drama, I can go on my app and do my medical blueprint and be done. It sends it to my doc. They don't have to worry about it anymore. I can make changes. I can send it to anybody and everybody that I know. If I think that this is important to making sure I get the care that I need, then I should just do it. And what we have to give people permission is to take some sense of ownership and responsibility around their entire care plan. We do a lot of making people feel guilty about not doing the care they're supposed to, or not eating the right way, or not exercising. We put a lot of guilt on people for not doing it right, but we don't celebrate when someone's a self-advocate. And we should celebrate that. When you say, I really want to make sure that when I go in for this next surgery, it's successful because I'm scared and I want it to come out the right way. One of the tools you can have is to give your advanced care planning document to your provider, so that they know what's important to you, so that your family knows what's important to you. Because it is, at the end of the day, all about you. This is not anybody else. The most exciting conversations I have, especially with people in their 40s and 50s, when they talk about this, is like, do you know who's going to make decisions for you if you have that unfortunate event and you haven't thought about it and they have no idea? Your 19-year-old kid in college is capable of making that decision for you. And they usually have a little freak out moments. So it's instead of letting the system worry about you, how about you worry about yourself and tell the system how you need to be cared for? Because that is actually what we want. We really want to know what it means to take care of you as the person in front of us, and how can we provide you with the best care that you want. And I can't, as a clinician, force that on you, but I can celebrate when you tell me, because that's really what I want to know. So if we switch and just, instead of making people think they have to go to their doctors for this, or to their lawyers for this, or as anybody else, that you can just do this yourself at home with an app. There are 1,000 apps out there. It doesn't even have to be our app, right? There's 1,000 apps out there. You just do it as another thing that helps you have a successful outcome. I think we'll get in a better space.
I completely agree with that, although I'm not willing to let the healthcare system off the hook. I agree that physicians do not have time. And I don't think it's a good use of their expertise and competence to spend the time doing this. I know very well that we can train people adequately. Mm-hmm. And actually, I think a good healthcare system would have an online program for those people who want to do this on their own. And there are people who can and want to do that. There's actually a research study that's just completing that shows that Respecting Choices is a little better than online programs, but some people can manage the online program and complete advanced care planning on their own. But I think health systems need to be held accountable, because I think this is part of good healthcare. Mm-hmm. And I think everyone benefits from it. I think it cuts down on overutilization at the end of life. I think physicians have better relationships and better decision-making with their patients. And I think patients and families fare better. And because of all of those good outcomes, I think health systems have a responsibility to provide this kind of support to their patients.
This has been a heck of a conversation. You know how honored I am that you both took the time to talk with me? I thank you both, and thank you for your work. Appreciate it.
Thank you. You know, Kathy, anytime you call, I always say yes.
Thanks to both of my guests, Dr. Bud Hammes, one of the original leaders in the movement to bring patient-centered advanced care directives into the medical system. He was the creator and former head of the program Respecting Choices until his retirement. He's also written a book, Having Your Say, Getting the Right Care When It Matters Most. Also with us, Dr. Nneka Sederstrom. She's with Hennepin Healthcare in Minneapolis, Minnesota. Her firm, UZOBI, has developed a digital tool that explains a client's preferred care needs to medical providers. And there's a link for more information in our podcast notes section. Join us for the next episode of Grave Concerns, a podcast from the End in Mind Project, made possible with support from listeners just like you and the Friends of the End in Mind Project. Want more information about what we do? Go to endinmindproject.org. Thanks for listening.